4 out of 10 Americans have either suffered or known someone who suffered from an eating disorder, which is definitely, more than I think most people anticipate, so 40% of people. Eating disorders, as we mentioned, they have super high mortality rates. Of all the eating disorders, anorexia nervosa has the highest mortality rate. So I guess if you want to kind of rank them hierarchically, all the eating disorders are above the other mental health disorders in terms of lethality, but anorexia nervosa takes the cake, so to speak. And of those eating disorders, or of anorexia, the 2 subtypes, which we'll get into, anorexia nervosa binge purge type is by far the most lethal. You can see that when a person dies from an eating disorder, when we're talking about lethality, it happens most typically in one of 2 ways. It's either happening because of medical complications, which are extensive, or because the individual chooses to commit suicide rather than continue struggling with the disorder. Eating disorders are highly comorbid with other issues such as anxiety and depression. And so sometimes the depression can also play a factor in that individual's choice to commit suicide. And then you can see down toward the bottom, a woman with anorexia is 5.6 times more likely than to die than another woman of her same age. So the health risk is massive. And the average age of death via eating disorder is 34, incredibly young. Most patients who enter treatment as adults come in to a program like we have at ERC, early 20s, college age, maybe a little bit older than that. And you can see they may have been struggling with their eating disorder 5-10 years prior to seeking treatment the first time. And so all in all, the course of the disease is rapid. So the need for, and this is something we'll be talking about and looking at, but the need for intense treatment is significant. Intense and as soon as possible. In one study, 3 out of 4 women stated that they were overweight, although only 1 out of 4 actually was. And I like including this statistic because I think it speaks to the body image problem we have in our culture. We have such bad body talk, and we hear it all the time, and it's just kind of, we get brainwashed. And it's just on our TVs, and it's on our radios, and it's in the books we read, and it's in the people we talk to, and we might not even realize that we're doing it. And part of that culture that we all live in, when we have a person who has the predisposition for an eating disorder, growing up in a culture like ours can be the tipping point for their disorder to activate. 2 out of 5 women and 1 out of 5 men would trade 3 to 5 years of their life to achieve their weight goals. Again, body image is a problem for us. The way we talk about our bodies is a problem. Okay, so shifting gears, we're going to be taking a look now at the Biopsychosocial Model. And this is a model that I talk to every single one of my patients and every single one of my families about when they start treatment. Within their first week, we talk about this because it helps remove blame. It helps kind of point us in the right direction in terms of treatment. And it helps understand, it helps our patients kind of start to understand and answer the question, why me? That's something I hear a lot. Why me? Why am I having this problem? Why isn't my sister? Why isn't my best friend? Why me? Why do I have to be here? I didn't sign up for this. You know, and there's a lot of times a feeling of deep unfairness when a person has to seek treatment for an eating disorder, particularly, you know, at a PHP or a residential level of care where they have to put the rest of their life on hold. And so what we found at ERC is that talking about the biopsychosocial model with our patients is really helpful. It starts to kind of soften the blow, or, you know, education is I think, a really critical part of the recovery process. So what you find when you look at the research is that eating disorders have about a 40 to 50% genetic component, depending on the person, and a 50 to 60% psychosocial component, depending on the person. There are some really interesting twin studies that they've done with eating disorders, where they showed that identical twins who, when one of the twins developed an eating disorder, the other twin was significantly more likely to develop an eating disorder compared to fraternal twins, where the rate was pretty much, the same as the rest of the population. And I can vouch for that because at ERC, in the time that I've been there, I can think of at least 3 sets of identical twins that we've treated both siblings who've both developed the eating disorder. So the genetic component is real. It's a real thing. So obviously biology is the bio in biopsychosocial. Biology plays in both DNA and family history. So eating disorders, what you find is that they are really highly heritable. If you have a first-degree relative with an eating disorder, your mom, your sister, you have your brother, you have a significantly higher chance of also developing an eating disorder yourself. Like I mentioned in the beginning, I work primarily in our adolescent program, and so we do lots of family therapy. And I couldn't tell you the number of mothers I've worked with who, kind of when everyone else is out of the room for a various reason, they look at me and they say, I had an eating disorder when I was little, or I had anorexia and I never got treatment for it. It's extremely common. I personally, was floored by just finding how common it actually is. It's really, really very common that we have kind of these family histories of eating disorder development, which makes sense when you look at the model overall. It's not a guarantee though. That's what I think, a lot of our patients worry that, okay, so I have an eating disorder, so does that mean that my kids are all gonna have it? Is this a guaranteed thing? Is this like a death sentence? And what we tell them is no. Because you can learn to stop the cycle. You can learn the coping skills that you need to cope with your emotions effectively and to teach your children to cope with their emotions effectively. And that over time, the eating disorder is not going to be as important or as significant for your family. So we have the DNA aspect, and then we also have family history. So what we see is that when there are other mental illnesses in the family, the risk of an eating disorder develops or goes up. So even if there are no other eating disorders in the family, sometimes people tell that to me. They're like, but nobody else in my family has this. Why does my child have an eating disorder? And so we start talking about the family history and the mental health history. And then it's like, well, I have really bad anxiety and my mom has depression and her uncle has substance use issues and my grandmother was schizophrenic, and the picture starts to become clearer. Which is an interesting thing, that just the presence of other mental health issues can raise the risk of eating disorder development in our patients. So that's something that's really important in treating eating disorders, is getting a thorough family history. The psycho of the biopsychosocial model is psychology. What we find is that patients who are naturally more anxious, more perfectionistic, obsessive, compulsive, sensitive, and intuitive. If you imagine all of those qualities on a scale, on a spectrum, when those people naturally fall at the higher end of the spectrum, they're more likely to develop an eating disorder. And when I rattle those qualities off in session, usually I just see like lots of heads doing this. Most of my patients identify very strongly with all of those qualities. And the thing about temperament and about being sensitive, being intuitive, that's hardwired. You're born that way. There's no changing that. We can't make you a less anxious person. I can't bring down your natural baseline level of anxiety. But I can teach you coping skills, and we can learn to make different choices. We can have different information, we can do things differently. So it's always kind of a both and. We want to share the information and provide hope that yes, this is how you are and this is how you're born, and you can be different. Things can be different. Social factors that we glanced over earlier, things like trauma, bullying, grief and loss, divorce, sports, dieting, these are all, obviously this is not an exhaustive list by any stretch of the imagination, but social factors have kind of the I don't know, distinction, I suppose, of being the things that pull the trigger a lot of the time for the eating disorder to start. So you can imagine that the biology and the psychology of the individual loads the gun, so to speak. The social factor is the thing that pulls the trigger and sets the eating disorder moving, sets the wheels in motion. And once the wheels are in motion, only significant intervention will be able to stop it. Eating disorders are not typically something people grow out of. And then you see in that little box down at the bottom, females between the ages of 12 to 25 are at the highest risk of developing an eating disorder. And I would say without, the data in front of me that the majority of our patients at ERC are in that age range. Which is great because that means that they're hopefully getting, treatment as soon as possible after the family becomes aware of the presence of the disorder. All right, so we'll take a look now at the different diagnoses. So now that we've kind of laid the groundwork, myths, data, statistics, prevalence, we'll start to take a look at the different eating disorder diagnoses. What you see on that overview page, we have anorexia, bulimia, binge eating disorder, and other specified feeding or eating disorder, or OSFED. And OSFED is the category that came in to kind of take the place of what used to be EDNOS, or eating disorder not otherwise specified, which was unfortunately kind of like a catch-all category. What you find, and we're not going to be reviewing OSFED in this presentation, just because I don't think there's enough time for it, but other specified feeding or eating disorders are where you find things like pica falls into that category, and all eating disorders that are, you can definitely tell that disordered eating is happening, but the behaviors aren't at the clinical threshold yet. So if the threshold is binging 3 times a week, the person's maybe only doing it once, or they haven't experienced clinically significant impairment in every, all the areas of their life or something like that. And so a lot of patients with eating disorders kind of cross through OSFED on their way to developing a diagnosis. So we just need to be aware that if we're looking at a patient, who maybe isn't at those hitting those perfect numbers yet, right, for us to put the stamp on it and say anorexia. That doesn't mean that they won't. We're just seeing a brief moment in that person's life, in a point in time that tells us what their behaviors are like now. But should, a couple of weeks pass, that can all change. Should another stressful life event happen, that can all change. And so it's not, OSFED is not a diagnosis that's like kind of like a whew, out of the woods thing. OSFED's a diagnosis that should send up your radar and your alert system, and we should be continuing to monitor this patient or helping their family know how to monitor them or start to intervene with them before the eating disorder continues to develop to a clinical level. Because it's really not a matter of if. Once that person has all those predispositions we talked about, and then they're, it's really just a matter of time, unfortunately, as grimly as that sounds.